Sugar daddy, ooh, sugar daddy. If you're down 'cause your A1C is high, all you have to do is listen to our guy. Sugar daddy, sugar daddy, sugar daddy, ooh, sugar daddy, sugar daddy, sugar daddy. The man with the diabetes plan, hey, sugar daddy, sugar daddy, hey, sugar daddy.
Hi everybody, I'm Dr. Frank Leveria, also known as Sugar Daddy. I'm here with my colleague, Carrie O'Day, and today we're going to be discussing that first nerve-wracking diabetes visit with a new doctor in a new office. And it goes both ways, not just for the patient, but also for the physician. So the right preparation can really set up the tone for better outcomes, better visits, smoother relationships with your healthcare team. So for the first time, we had patients that were referred to my office or that they self-referred to the office, and they didn't know what to expect. So I learned to kind of set the mood by asking them to be a little bit prepared by being and bringing their information, coming early, etc. We'll get into that in a little bit. But more important is that when I had patients that were prepared, I got the idea that this is an engaged patient and they want to own their own care and they're advocating for themselves. So I really welcome that kind of patient, and I think that's the attitude you have to be in, be prepared when you go to the office to answer questions, etc. So anyway, Carrie, we both have seen how little preparation can go a long way, and why patients expect when they walk in through the office for the first time, you know, what am I going to do, where is it going, etc. So preparation is very, very important. So what do you think in a patient checklist should it be there for them?
All right, so coming for your first visit, I mean, this is sort of basic, but sometimes you forget. Arrive 30 minutes early. That way you'll have time for insurance, checks, for paperwork, and then you'll be in the room at your actual appointment time, which is important. And then bring your recent labs, imaging, even call ahead, see if the physician wants the imaging or the reports. You may not have to go actually get the imaging, but surely they'll at least want the reports. Bring a list of all your medications, including the doses and the times, not just what you take. And don't forget your over-the-counter medications and supplements. These all matter. Another good idea is, we're talking about patients with diabetes. If you have your glucometer, bring it along. Bring your log. It doesn't matter if it's on a piece of scrap paper with some other writing and some specks of blood, but bring that along. We need to know, when are you checking? Are you checking in the morning? Are you checking pre-meal? Are you checking after meal? And then write down your questions and prioritize them, because you may not have time to ask all of them, but surely the most important ones will be answered. And then think about your family history. There's a big question that is important. And maybe some past, if you've had any past weight change, whether it be up or down, your exercise habits, your alcohol use, smoking history. And if health literacy is a challenge, or even sometimes if it's not, just so that you can sort of help spur your memory from the visit, bring someone along, a family member, a friend. And lastly, sometimes when you come for that first visit, if your physician has time and wants to do a complete check, they may ask you to take off your socks and shoes. So make sure you wear something where that would be easy for them. So that's the patient side, but what are the doctors looking for in that first visit, Frank?
Yeah, so, you know, the key things that I'm looking for is, when were you diagnosed with diabetes? And you'd be surprised how many people really can't recall or weren't sure. I always like to ask what type of diabetes they had, and many of them don't even know there are many types of diabetes. And more importantly than anything is, how long have you had diabetes? Because that is critical in knowing what the beta cell, the cells that make insulin, where are they along the road over all these years? It might tell us that, hey, they might be running out of insulin because they've had the disease for 15, 20 years. So knowing how long the disease duration it's critical. Then I like to ask about risk factors. You already touched on the family history. That's very important. Your parents, aunts, uncles, brothers, and sisters have diabetes. They're high risk. I'm going to ask them if it's a lady, if they had gestational diabetes at one time. What's their lifestyle like? What other comorbid conditions they have? And I explain to them what a comorbidity is. That these are other disease processes that kind of attach themselves to diabetes, hypertension, lipid issues, fat in their blood issues, and so forth. Now, one of the more important things that we all do, even though we don't think about it, is something that is called motivational interviewing. And that gets us a quick feel about how the patient feels about change. You know, are they like very proactive type of people? Are we going to have to spend a lot of time convincing them that this is for the good of your health care? So we go into that inadvertently, and we get this information very quickly that, hey, I have a patient in front of me that wants change. They're tired of feeling bad. So that's called motivational interviewing, very important. And then as we've asked to bring some of their records with them or have a feel for what they're doing, we like to know, what was your past treatments? What medications were you taking before? Did they agree with you? Did you have a side effect? We need to know all of that. Talked a little about foot checks and physical exams. I know that by the second visit, we have a sign in the waiting area, in the room, in the examining room, asked to take their shoes and socks off, because it's very critical to see if they have a neuropathy, peripheral arterial disease, they have an injury. I've always been surprised when they take their shoes and socks off what we find under there. So that's an important, and if you want to gauge any of your physicians, healthcare associates, and how good they are, if they're asking you to take your shoes and socks, they're going to be with the program. These are good people. And finally, we're going to start to build a long-term care plan, and that's important that we go with it. The world is changing fast, and it's just the doctors calling the shots. How does this broader team fit in now?
So it's more than just the doctor, right? I think patients have probably seen that. We have PAs, we have nurse practitioners. So sometimes, the physician may not be able to see everybody, but the physician may not need to see you every visit. Maybe you could see the PA, maybe you could see the nurse practitioner. Sometimes there's even a little more time there, and sometimes maybe the connection, you might tell the PA something that you don't tell the physician. So that's important. We also have diabetic educators that can help you with anything from your medications to the technology that you're using to check your blood sugar. And then there are dietitians. Well, it's always tempting to ask a physician, I have a whole list of medicines about my diet. Those might be better with the dietitian. They could spend more time on that particular, those questions you have. And then of course, there are the specialists that you might need now or that you might need in the future. Maybe somebody, ophthalmologist, the nephrologist, take care of the kidneys. So those are all parts of your healthcare team when you have diabetes. And they can help, they can work together and they can help tailor your plan so that you do have a better outcome. Also, this is kind of a time to mention the electronic health record, because I think those of us who remember a time before there was an electronic health record maybe remember a little more of the engagement, and it feels a little disengaged when your provider is typing and looking at the screen and not looking at you. But this is even more important now with these big teams, because if you see the physician one day, you come back in a few days and you see the PA, then you see the dietitian. Everybody needs to know what's going on, so that needs to be documented right away. So that's what we're doing, just so patients know. And then of course we need that information in the electronic health record to help us navigate these prior authorizations. People have probably heard about this. When you need medications that are newer or more expensive, maybe you have to document that you've tried other things that haven't worked. So all that's in the electronic health record. And then it's also important to be able to communicate. Every provider is not in the office every single day. So that electronic health record is the way that people can communicate at every time, every day, every evening, late in the day, whatever it may be. So Frank, patient is prepped, the team is ready. What should they expect for their ongoing care?
Well, I think we need to establish a treatment plan that with very clear goals. We need to get not only your blood sugars under control and minimize highs and lows. We also have to think about lipid issues. We know for a fact that after a certain age, according to the standards of care from the American Diabetes Association, which we're using in these conversations, we let the patient know that maybe by age 45 they should be on a statin and see if they tolerate it. And there's high intensity and low intensity. We're going to get into that conversation in some other episode, but it's not just about blood sugar control, it's about lipid control, it's about blood pressure control, it's about protecting the kidneys, dealing with obesity. And again, we'll get into that at a later time. We need to talk to them about how often do we do labs? How do we do an A1C once a month or every 90 days, every 3 months? And a lot of patients don't know about that, so we cover that. If we start you on medication, how soon can we check the lipids? And we give them dates so they kind of know what to expect. And a lot of the patients I remember always asking, so which is the best glucometer? Which is the best blood pressure machine? And my standard answer was the one you get and use regularly. So again, one of the things that we really push is encourage them. We have to, realize that this is a partnership, that this is not on the doctor, it's not on the patient, it's a team, and there's a big team. You already alluded to all the folks that are involved.
Okay, so I guess key take-home messages, right? Number 1, prepare for your visit. It sets the tone for better outcomes. Number 2, bring your information and make sure it's organized. Bring your labs, your medication, your history. Number 3, remember, healthcare is a team sport, so everyone's involved. Use all the supports that are available. And last, long-term success means regular check-ins and a clear plan, cooperation, communication. So Frank, what's coming up in our next episode?
So our next episode is going to be Call It What You May, and we're talking about bad stigmatizing words, fat or obese or heavy, but we're going to have a conversation on that. So please subscribe to Sugar Daddy Podcast, and remember, you can do this.
If